Guys, I'm going to try and give you guys a quick rundown of a room check. I figure it's probably been a while since you guys have done this, and maybe this might refresh your memory and get you more comfortable to start back in the OR pretty soon and pretty much start off on your feet running. So as soon as I come in the mornings, I'm always making sure I have all my emergency stuff. I turn my ventilator on or my anesthesia machine on right away. I sign right into the computer system because I actually want to multitask if able to. So I'll sign in. I might not multitask today in order to be able to show you a better video. So as the machine is turning on, I'm going to start to just do a quick once over of, let's stick to the machine maybe, of the machine. So I'm going to look on the back of the machine quickly. I'm going to quickly open up my cylinders for my emergency oxygen, crack it open about quarter way, close it. That's gonna create a pressure between the bottle and the machine to show us what the most recent pressure of these E cylinders are. So open, close. These are my main gas lines. So I have air, oxygen, nitrous. I'll follow those up to the ceiling. I'm also making sure that my vacuum, which is purple, is nicely connected, good to go. This is a little needle valve down here, which can increase or decrease, as you see right here. It's a little knob that can turn in case you need more vacuum, less vacuum if it's not working. Again, I follow it up to the main housing right here. Looks like my oxygen's in the green, blue's in the blue. This is for suction, vacuum right here. The only one I'm missing is air, so found my air. Looks like the air goes all the way up to the ceiling. So everywhere is a little different. Again, when I check the machine, it's going to tell me if I actually connected to the wall, but you're no problems in not looking, you know. So now the machine's on. So I come back over. Since I'm already looking at the main feeds, I'm going to just check the main feeds. Everything should read within about 3 points of 50. So I got 50 under oxygen, 50 under nitrous, and 50 under air. If it's ever less, you should call someone. There's a problem. And now I check what my emergency bottles are. So I've got 1800 for O2 emergency and air is 1800. If it's less than 1000, you should replace it. It's kind of the rule of thumb, so you've always got a good reserve. I think your oxygen, for instance, only has, I think it's around 400 or 600 liters in it full. So if you're running at like 15-liter flow rate, you know, it can go empty pretty quickly, especially when you're running a ventilator, and if your flows on the ventilator are anywhere from 40 to 60 liters for every tidal volume breath, and then obviously based on your tidal volume ventilation, you can run through it pretty quickly. So replace it after 1000. All right, so my machine's on. It's telling me I got to do a checkout. So first thing I normally do is I do the low peak test right here. So I'm going to go and turn my canister to 1%. I'm going to switch my system down to the, I'm going to bypass my system to this little valve here, this common gas outlet. I'm going to grab my little bulb thing, and I'm going to squeeze this until all the air comes out, and it holds the suction. Hopefully it holds the suction. It should last for about 10 seconds. Remember, I got 1% on the SIVO, and I got the bulb down to suction here. Some people will do this before they open up the SIVO to 1% and then see if it holds and then open up the SIVO. What that does is it eliminates whether the leak is involved with the vaporizer or not. But if you have no leak with the vaporizer open, then you know the whole circuit's good. So that's my little trick. So I actually kind of lost suction here. So we'll count 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5, 6, 7, 8, 9, 10. All right, we're good. All right, so close your SIVO. Otherwise, you've got gas now going to your system when you start doing a ventilator check. And when you go to turn up your flows to start your case, you're going to have gas everywhere. All right, so if you had touched the low peak test, it pretty much tells you what to do. It looks like they say 30 seconds. I've always done 10. So do 30 seconds. All right, we're just, for teaching purposes, we're going to say that we passed. All right, so now let's go back. Click that, and we're going to go to the next screen, which is the full test, right? And pretty much you just follow this all the way through. So the first thing you do is you're going to go to your ventilator on that little throw switch, and then you're going to leave everything open, right? So you have your circuit attached here. Everything is attached, as you can see. All right, so, oh, you know what we forgot was the flow sensors. So flow sensors are right here. They're just these little black things on the inside right here. I'll actually pop this out and show you. Those are your flow sensors right there that are numbered. The 07, 17 and stuff, those are your flow sensors. You don't need to fully remove this, but I'm gonna remove it and then just show you that that device right there that has like the telephone wire hooked up to, that's your oxygen sensor. So that's how you actually calibrate your 21% and your 100% oxygen. Whenever that doesn't calibrate well, you can manually calibrate it by taking this out. So let's hook that back in. We only need to remove this just a little bit. Okay. Once you see the no inspiratory flow, no expiratory flow sensor, that means you've done your flow sensors. So then you can pop this back in and you can lock it. So we've done that part. So we can go back to doing what we talked about. So we calibrated our flow sensors, which was 4, and now we can start this vent check. So okay, let's see what we did wrong here. We did open patient Y. You know what we did? So, as I'm talking, you notice the symbol up here. This symbol says that we've bypassed that circuit, right? And we did that for a low peak test. So it won't let you do the checkup because the right circuit is not selected. So we forgot to turn our common gas outlet down here, and this switch, we forgot to turn this back up. That was the problem. So now we can hit start. And the flow sensors are still fine, they checked. So this is a quick test. As this is testing, I'm looking around. Do I have a bougie readily available? Nope, that's extra suction. Here's my bougie, where is it? If there's an emergency, am I ready to go? Some students like to have out oral airways, 2 sizes ready to go. Maybe start preparing your tape and stuff. Put your tape on your mask to prepare for the eyes. The next thing I'm looking for, which is really important, is an Ambu Bag. If my machine fails or if I'm not confident the machine is working, where is my Ambu Bag? I don't see it. Sometimes it's on the back of the Pyxis. And so everywhere it could be a little different. So here is my Ambu Bag. So I have a bougie, I have an Ambu Bag. I also have another circuit. In case this circuit fails, I can replace it quickly with another circuit. So this is alarmed, it's ready to do the next test. This is the longer test. So we now occlude the Y here. You can take this and occlude it. That's what it's asking me to do, as you can see on the screen here. And I'm going to occlude it down below. Some people can occlude it with the little plastic cap that it comes with. Make sure that you have caps on all the little ports here, or else it won't work. And I actually like to run your circuit test with the CO2 attached. You can see this wasn't attached. So again, okay, we're missing something. I like everything that's going to be on the patient to go through these circuit checks, because if you do have a leak, you're going to know. And if the leak is because the CO2 housing right here has a crack in it, how would you know? You would never know. And you might be able to see on the CO2 waveform that the waveform was off, right? It's showing a waveform of a leak. But it's nice to kind of problem solve this ahead of time and not be in the middle of an induction in a case where you're looking at a weird waveform on a capnogram. So if it's going to be attached to the patient, it should be part of the circuit checks in the morning. You shouldn't avoid it, just because you'll have a better chance of the circuit checking out with having less hardware on there. The whole point is to check if all these little plastic pieces have no cracks in them. Okay, so now we're good. Had we not put that on there, it would have alarmed. We'd have to redo it again. Okay, so we got a bougie, we got an Ambu Bag. Next thing is well, hey, sevoflurane, do I have enough gas in there? You just fill it up. Fill it up, because the chances are when you're new, you're going to be busy during cases and forget to fill it up, and when it runs out, you look bad. So fill it up now. I'll leave it. I think it's fine. I have a train of 4, so what I normally do with the train of 4 is I turn it on, and I'll put the little metal barbs right here on here, and I'll actually test it. So I'll go right onto my wrist here. I'll go right onto my wrist and do my ulnar and see if it actually works. A lot of times people put on the train of 4, it doesn't work, they give more muscle relaxants, and then they realize that it never worked because the batteries were on their way out. So not a bad idea to check that. All right, next thing is you kind of come over and you look at the wires here. Do you have all the main components of doing general anesthesia? So do I have EKG cables? Yes. Could they be better organized? Sure. You can lay them on the bed if you think that works better. Do I have an O2 sat and an O2 sat probe? Yep, it looks like I do, right? For the finger, I got a blood pressure and I have a temperature. That looks pretty good. The other thing you might want to think about is you open the top drawer here, you might want to see if you have an ear probe. Sometimes the finger probe doesn't work. It's nice to have an ear probe. It's a luxury. You don't always have it, but we do have an ear probe. All right, perfect. So next you could start getting your airways ready, right? Every day you're in the OR, you should always, every day you do anesthesia, you should always have a blade to intubate. So does the blade turn on and light up? Yep. And then just a reasonably sized tube. So I'll usually have like a size 7. And I usually leave it in the top drawer. Everyone's different. You should kind of do whatever your local hospital does or your local anesthesia department does so you're all consistent. The next drawer below, I always want to make sure I have a size 3, 4, and 5. So I have a 3 LMA, or 4 LMA, 4, let's see, we have a 3 right here, and let's see, we have a 5. We have a 5, and we have a 5. You have all 3 sizes because it's along the difficult airway algorithm. If you can't mask, you can't intubate, and oral airway doesn't work, you put an LMA in. So you need to have all 3 sizes so you're fully prepared for any size patient that you have. All right, so again, it now alarmed again. So here's your next step. If you guys read that quickly. And now it wants you to switch the setting to the bag mode, and then it wants you to keep it occluded, and you want to turn your pop off to between 30 and 70. So I switch over. When I close my pop off, imagine putting more of your thumb over the hose, right? So air can't come out, and it causes a back pressure in the bag here. So I hit start, because that's occluded between 30 and 70. It's not too picky. It's gonna go through that check. And now it's actually checking that circuit there for compliance and also for leaks. All right, perfect. So we need a size 7 tube. All right, so I got a size 7.0 tube. I think it fits most people. So it's probably the easiest tube to grab. It might be on the smaller side for most men, for larger men. It might be on the bigger side for really small women, but it's usually a good emergency tool. You have a 7.0 tube. So when you get the tube, you have to check the pressure and the whole, make sure that there's no leaks in the cuff. So you inflate your cuff every day, inflate it, take your syringe off, and then push on the bulb here. And if it keeps it there, it's good. Then the last thing that I do is I like to add a little bit of a curve, like a hockey puck to my ET tube, as you can see here. I find that I have a better angle when I put the tube in. So both things usually go in a towel. We don't have any. It's gonna go in the second or top drawer right here. I know my airway, if I have an airway emergency, it's ready. If it's just a general anesthesia case, hey, so be it. So that's done. I have airways, LMAs, I have a bougie, I have an Ambu Bag, right? My train of 4 works. So my machine just alarmed. This is the part that most people skip over. So if you read this closely, what it wants to know is the circuit O2 accurate? So when you follow this prompt, which is you need to turn the vent to the ventilator, or the switch to the ventilator, you want to open the patient Y, and you need to open your circle, or open up your APL. So what it wants you to do is it wants you to see if the FiO2 goes to 21%, and it stays there. What happens is sometimes the O2 sensor needs to be calibrated, and it's going to read like 17%, when we know that right now in the room that we're breathing, it's 21%. So if you're reading a number that's really far off from what the room is, which is 21% oxygen, which it is in the whole world, you need to recalibrate your O2 sensor, which I think I'll show you right now because most people don't know how to do this. So good to know. So if that, instead of staying stable at 21% like it's saying, if it says anything other than 21%, it's time to do the O2 sensor calibration. So what we're going to do, come down to the flow meters here. We're going to pop this off all the way, like I was saying you could do earlier. Pop this off all the way. You run the risk of, after checking your circuit, you might create a leak because you don't put things back together. So maybe it's better to do this early on. So now with your O2 sensor, you first need to take the wire out, because if you twist the wire, it's going to break. Now twist this out. It's like a screw. Here's your O2 sensor. I kind of make sure that there's no oxygen in it. It's just got room air. I'm going to reattach it. Okay, you just let it hang here. It's hanging in room air. Next thing you're going to do is you're going to say done. In order to get to the screen, say done again. I have to usually say start case. So now system setup becomes an option. So you click on system setup, you go to calibration, and you want to check circuit O2 cell. So it's telling you it's reading 21, so it's accurate. But you know what? Let's just do the test, okay? Let's just recalibrate it. Because let's pretend, oh, it's saying 20, 21, so let's pretend it says 18. So we're gonna hit start, and that's it. It starts calibrating the O2 sensor. So we just fixed a problem that we might have all come across. All right, so we got more time now. Time to maybe go over and focus on the Pyxis. Some people will hook up leads, stickers to these things. I usually just leave them on the counter. Do whatever makes you happy and keeps you in a good routine. Some people, well, not everyone, pretty much everyone wants to make sure you have a head pillow too. That's there. Second IV pole is good. And you have clips for both sides for the curtains. All right, so quickly, I went to sign into the computer system and the keyboard wasn't working. If the keyboard's ever not working, don't waste your time trying to bang on it. Just come back here where the USB cords are, pull them out, put them back in, it starts working. Another thing is with the keyboard is it gets sticky, so you think you're typing the letter for your password or your login and it's not actually going through. All right, on to Pyxis. Make a bunch of syringes, so if you need something, you have something that you can draw up quickly. Luckily, these come with the syringes already on, the needles already on. I always have 2 syringes of propofol. You want to shake it, clean the top, lidocaine so stuff doesn't burn with the probe. It also helps with decreasing airway reflexes. Fentanyl's pretty good for everyone. Pick and choose what narcotics you want. Depending on the case, you might need some. Versed, plus or minus. But always 2 syringes for propofol, 1 to go to sleep, 1 for emergencies. Always have an emergency one available. When I open up my Pyxis, I'll find stuff in here and I throw it away. I don't know whose it is. I don't care. I toss it. Anything that's in there is gone. So I had some syringes in here. I have no idea when they're from. Tossed them. This is just disorganized. If there's too many, the drawer won't close. I take them. I go on the side port here. So let's get this out of here. And I return them. So if things are overstocked, I want to clean this up. This is my clean area here. As I open the drawer, make sure that all your stuff is stocked and that the numbers reflect what's on the screen. If you have not enough of stuff, you need to do a count. You need to verify your counts. The top drawer has the emergency stuff. So, hey, do I have succinylcholine if I lose my airway, with or with planned or unplanned, right? Glyco for people who need something for secretion manager or bradycardia, antibiotics, atominate for sick people. I have some low pressor, which you could use. Esmolol is always good to have around. As I open it, I have epinephrine for emergencies right here. Narcan, if you give too much narcotics, you can recover. If I'm in a vascular room, do I have heparin? What else? Vaso is always good for people who are vasoplegic. Albuterol for the bronchospasm, that's the emergency, so it's always good to have. If that's not available, 10 mics of epi at a time is okay. Not ideal because of the cardiac implications. Those are probably the big ones. Oh, and Sugamidex. If I end up giving rock and I can't get my airway with rock, even if I'm not using RSI dose, I can get them back fast with the Sugamidex. It's a game changer. And again, making sure your numbers match on here. All right, so I had to switch rooms because people came in and I felt really embarrassed. So the only thing I didn't do yet was suction. Check to make sure your suction works. Tuck your suction into the bed so it's always at the bed with you if you're going to be doing general anesthesia, so it's readily available and you know it works. So I'm pretty much done. I'll put whatever I'm doing for the anesthetic case on top. So in my other room, I put my LMA up here with a tongue blade, some lubricant, and I think a temperature. So it just reminds you of everything you need to do when things are busy and everyone's looking at you like, are you done? Are you ready? Can you talk about the case? So everything's up here. So if you see something that isn't in the patient or on the patient, you can remind yourself. So that's all up there. I had my tape, like I said. My machine's fully checked. I did screw back in the oxygen sensor, screw it in, then take the wire and attach it after it's seated properly. Then put your flow sensors back and latch it closed. So I think we're pretty much ready as far as the machine goes. With my meds, I just drew up what I needed, so I put it in the second drawer. It's probably gonna be an LMA case, so I drew up knowing I'll need the fentanyl. I drew up a stick of propofol and a backup stick of propofol for emergencies. I have some lidocaine for like comfort, and also helps with putting the LMA in. And that's pretty much it. I don't drop really anything else. I know everything I need is in these 2 drawers, and my stock is okay. So if I need emergency things, they're there, and I have syringes. The next thing I did was I drew up my fluid in the bottom drawer. At this facility, we have to hang our own fluid, and we have to do our first IV during the day. So don't forget that, guys. Otherwise, it looks pretty good. The one thing I want to say is make sure you have a French suction catheter, which is these things. The French catheters are really important because you can suction down the ET tube to see whether your tube is kinked or if something's occluding it, like a mucus plug. So did that. And the next thing is just Epic. You might be a little uncomfortable with Epic. Oh, sorry. As I'm sitting here, do you have a stethoscope? Don't come to clinical without a stethoscope. If there's not one in your room and you forgot one, get one from the workroom and have the tech's numbers on hand so you know where to find them to find the equipment you need, especially if the room's not stocked right. Always have a stethoscope. You are not prepared to clinical if you don't come with this, okay, guys? This is also nice to have, and I'll start having you guys use this, the head straps, so you guys can be independent when you start your inductions. But all right, so computer charting, you'll be a little uncomfortable, but I'm going to step you through computer charting really fast, or just preparing your chart for the case. So you find your, you go to this little symbol up here, which opens up this screen, what you see right here. I'm in room 11. Oh, nope. I'm going to go up to more reports. I'm going to go down to charge. Let's see. Now I can see it. Okay, go to charge SRC. All right, so opens up charge SRC. I'm in room 11. I'm going to scroll away from the screen so you can't see the patient's name. Perfect. I'm going to go to Epic or Interop right here. Once I go to Interop, the charting has changed a little bit. It's a really ugly screen. I hate it. I'm sorry, guys, but I'll be honest. So you go to macro. You want to set up your macro, which is what it does is you want to figure out what kind of case are you going to do, because it's going to pre-populate buttons that are automatically going to generate either medications or events that are appropriate to what you're doing. So this really helps you. So I'm probably going to do an LMA. So I click adult under favorites or go under public. You'll find it adult general LMA. Now look and see what it gives you. It's going to open up all these options on your screen. So these meds are now available. So it makes your life easier. And then right here, all these little events that you click on, when you're too busy to chart, you can click on in order. They're all going to show up. So it's going to make your life easier. It's pre-populating. So I like that. So I'm going to hit accept. Now my screen has those meds available. And if I were to start clicking buttons, they're in order. Anesthesia start, right? And then you have like in the room, start vitals and all that stuff. So it's making your life easier. The next thing I'm going to do to prepare my chart so I look really organized is I'm going to add everyone's name. Now your name's not normally added. So I look up, my name's here, Dr. Lone's there. What's up, guys? All right, back in business after being embarrassed again. All right, so my name's there, Dr. Lone's name there, and hopefully you'll add yours. But what you want to do is you want to click in the box under start. So what this is saying is it's going to assign you to this room as soon as you hit the start button on the patient chart. So it's not saying that you're taking care of the patient now. What it's saying is when you click this event, this icon here, that means you're responsible. And when you hit stop, anesthesia stop, you're no longer responsible. I plan on doing the whole case. It's only 8:30 in the morning. So again, this is ahead of time. You put your name in and mark yourself as being